Hello and welcome to the Crystal Podcast on iCode Media. Today, I'm excited to have a conversation with Drs. Harvey Hanlen, Dr. John Nolan, and Dr. Jim Stringham. We're going to talk about some new technology related to caratenoids and macular degeneration, and that's the LifeMeter. And so I want to kind of open it up to the problem of measuring caratenoids. And it's been a historical problem. Harvey, tell me about this problem historically.
Well, the issue is that if we're trying to measure macular caratenoids, it's been almost impossible to accurately do it in our offices as a practitioner. They do it in the labs, and the scientists do it, and it's very sophisticated and takes a while, but when you're in your office, you need to make sure that you can do a test that's quick, accurate, and you can explain easily to patients.
And so the downside with that is that obviously historically what we've had is we've had a couple different devices or widgets that occur. One is, I've seen one that's been around for a long time, measures macular pigments. And the challenge with that is it uses technology that relies on a patient's response. Jim, do you want to talk about that at all?
Yeah, that's right, Chris. Historically, we've seen clinical implementation attempts with flicker photometry, and so this is a subjective test, of course, and I've used this in my lab over the past 25 years, and it can be a good measure of macular pigment, but there's a lot of subjectivity, there's variability that can be difficult for patients to do, it can be time consuming, and so obviously if you're looking to baseline and track a patient, you want something that's not only accurate, but it's going to be less variable than something that's all over the place, so you can have confidence in the measure. And so despite many, many attempts at this heterochromatic flicker photometry method, largely what we've seen is they become paperweights in the clinic, in the office. So yeah.
Harvey, did you have one of these before? Did you ever have an office measuring like macular pigment device?
We did not, because the one that was available at the time from another company I didn't think was accurate enough to run in the office.
I mean, we felt the same way. We didn't ever have one either. I know a lot of people I knew some people who had them, and what Jim's describing is the exact challenge with them is the reliability and repeatability. And John, you and I have had this conversation before as well. Related to the devices that you use. Jim, you've used that device, that MPOD device, in your studies. But John, you have used that, but you've also used one that's sort of like a lab device.
Yeah.
What makes that different?
Yeah, that's a great question. Because that device was from Professor Billy Wooten, his invention, essentially, the densitometer, the original densitometer. And, when we started this kind of research, Chris, over nearly 25 years ago, we didn't have access to the type of technologies that are in eye care today. So we'll come back to that in a moment. But in the research world, we didn't either. So, I actually had a device before Professor Wooten's from University of Westminster in London, Professor John Malario, and it was a flicker device too, but it was highly limited in terms of what it could do, because to your question, in order to do an accurate measurement that's reliable, that if you retest you get the same, you have to optimize and customize, if you like, the system for that participant, for that patient, okay? And that takes a piece of work, a significant piece of work, which takes time, which is something that you don't have in the clinic. So even in a perfect case scenario, we have another problem, and that is if you were to do a measure 100% accurate, you're only getting a measure on that line of macular pigment. So if you think of the macular pigment like a mountain, classically you have a 1 degree stimulus, so you're measuring at the edge of that 0.5 degrees of retinal eccentricity, and there was maybe 15 years of science that came out with that research measure. What happened in real time, and I saw it happen, was companies tried to take advantage of that science and commercialize devices, but with the cost that they couldn't provide this big system that you're referring to that we have, which was set up to customize the system, so just for CFFs, lens, age, all of these factors that are really, really important. So it got, everything for me very quickly got lost in translation to the clinic, and there's only one worse measure than not having a measure, and that's a measure that's not accurate.
Yeah. Well, I would say it's probably worse, right? Like having an inaccurate, unreliable measurement, as you talked about, it winds up in the closet, and and then it's not repeatable. It's actually detracting, because if I can't know that this reading is valid, then, do I make a strong recommendation? Do I make a weak recommendation? Is the eating green leafy vegetables, is that acceptable? So, I mean, it opens up a whole can of worms clinically.
But even if it's not valid from a normative perspective, right? At the very least, you want it to be unique to the patient. So in other words, if you change their lifestyle or give them a supplement, that if there is a positive change in those scores, that the system is capable to detect it. And the variation with in-test retest on these devices is greater than, change that you would expect to see with appropriate supplementation. So for me, it was, for many years, I've been saying this unapologetically on the stage for a long time, that, I think the optometrist needs to be protected from the voices that are over-commercialized, that are not valid in terms of delivering what they claim upon. It does a disservice to your industry.
Mm-hmm. Yeah, I think what I always think about when we're thinking about disease state management, and this is pretty much a comment for you, Harvey, is where we get bogged down is if we don't have good repeatable measures of what a patient is dealing with that are is as objective as possible before we start a patient on treatment, and then after we start a patient on treatment, we're sort of wondering how effective that treatment was. I see this still continuously in doctors who are trying to integrate ocular surface disease management into their practice, and the common mistake they make is they rely too heavily on patient symptoms to drive what the next step is. They know what they're looking for. They're looking for staining, they're looking for other things, but they're not being super accurate in the documentation of those things. They might say corneal staining as opposed to like 1+ inferior SPK or 1+ temporal lissamine green staining, or an osmolarity measurement of 345, and then we put a patient on treatment and they come back and they still might have some corneal staining, but our measure of success is, do you feel better? And if the patient doesn't feel better, but we don't have any other reliable, repeatable clinical indicators to know if we actually made that patient better, then we wind up going down this rabbit hole of like, well, I can't tell if I put this patient on X medication or Y medication, why they're doing better, because sometimes they do better and sometimes they don't. And then you don't have any guidance. And I think in a lot of ways, that's where we've been within carotenoids in the macula. So then kind of fast forward, Harvey, into the skin carotenoid measures. So we've had something that measures carotenoid in the skin. It's been around for probably 4 or 5 years. I don't know. I haven't evaluated it too much because it is really linked to the sale of a specific carotenoid. So, that limits a lot of what you would want to do, especially if there's better carotenoids available. So that's why I haven't really evaluated it. But to me, it seems like if we now have the ability to say, okay, this is what you are on this, or taking nothing, and we can repeat that in a month, 2 months, 3 months, there's a lot of strong clinical value to that.
I totally agree. And in fact, the new instrument, the LifeMeter, is very, very accurate. And not only is it accurate, Chris, for the doctor to know how the patient's doing, but for the patient to know how the patient's doing. We have all of our patients that they live on numbers. They're diabetics. They want their A1C. They're glaucoma patients. They want their IOP number. Well, when you put a patient on a supplement, they often ask, Doc, is this working? Well, we haven't been able to really tell unless they've given us some response like, I'm seeing better at night, or my general vision seems better, things like that. I think when you tell a patient that their number went from 200 to 300, and you know what the standard is, and we can talk about that shortly, is they feel better and they'll stay on the supplement. If you sort of don't know what to tell them, and you're wishy-washy in the few minutes that you have with that patient, what are they going to do?
Yeah.
They'll finish the bottle and they may buy another one, they may not. They need to see an objective finding that can help them.
Well, especially when we're dealing with a condition like macular degeneration specifically, is that it is going to get worse. I mean, there's nothing we do that's going to make it better at this point, where all we can tell the patient is it's not getting worse.
Right.
And that's a challenge, right? As opposed to being able to say, yes, we're seeing clinical findings on your macula that haven't changed, but also your numbers have gone from here to there, or even better, Mrs. Smith, just like we do with intraocular pressure. Mrs. Smith, it's looking like your pressures are a little high today. Have you been adherent to taking your medications? Are you missing drops here or there? I mean, we can have the same conversation now if we have something like the LifeMeter that allows us to understand those numbers. And really, frankly, it really allows you to do the Pepsi Coke challenge in some ways. Patients come in and I got this at Costco, and I can get this big jar of carotenoids that say compared to PreserVision, AREDS 2, or I don't think they're comparing themselves to MacuHealth yet, but the point is that they're in the consumer's mind, this is the same thing. Well, honestly, like I have this, my point to the patient would be, all right, if you're taking that and your levels are 500, God bless you. Keep taking it. Right. Mm-hmm. Like, why am I going to argue with that? Right. But if you're taking it and your levels are 200, then, okay, well, now we have a better conversation. Well, we're going to put you on this other one. We're going to start this other treatment. We'll see you back in a month, 2 months, whatever. And now we can see, all right, we're going to remeasure this. We're going to recheck that. That, I think, becomes way more empowering as a clinician.
I agree with you. One thing I want us to be careful about, Chris, I don't want us to get stuck in the cubbyhole of macular degeneration.
Agreed.
Because it's much broader than that. Visual performance in a younger person who may not be seeing as well qualitatively as they may see 20/20, but their quality of vision is not that good. And a lot of times it's because they have low carotenoid levels and their visual performance is bad. So this, I think, gives us an approach. We don't have to talk about a disease process. We can start talking about visual performance now, irrespective of age.
Yeah, well, and Jim, you really got my dad with that sort of idea. My dad's 60, so I'll be 42. He's 60. He'll be 65 this summer. And when he had a conversation with you about a month ago now, and he was like, I'm convinced my number. I think so. When I checked my number at Seco, I was like 410, and he checked his number. I think it was like 250. And so he's been supplementing since then. He's got no macular degeneration, is what you're talking about. He does have a family history, but he keeps in good shape. He eats well, and so he's excited to retest. What's he going to see after a month of being on MacuHealth specifically?
Well,
the LMZ3.
Well, right. What we've seen is you can move the needle. And the lower you start, you have a little bit higher ceiling to go.
I actually probably jumped the gun a little, Jim. So I'm going to take a step back and say, okay, well, what's our normal ranges? What are the normal numbers? And let you start there, and then we'll go into what is he going to see?
Sure. So from the literature, and there are over 30 publications on this device, and then in my personal experience as well, just measuring, hundreds of people at this point, the average is somewhere between 250 to 280, somewhere in there, and that's generally the U.S. population.
And optical density, right?
That's an optical density measure. It's a concentration of these carotenoids, just like we measure with optical density in the eye, and so they're concentrating at virtually the same type of levels. There's a strong correlation between skin and eye, serum as well, and so what we've seen, and we've got a couple of cases. One of them is my daughter. Another is one of our managers at work, Emily. And so they both start in the mid 200s, kind of like your dad. And so they start supplementing. And within about 30 days, we're seeing roughly 100-point change. Now, you extend that out, and again, it's an accumulation process. And so, 60, 90 days, I think that judging from, and again, this is a couple of individuals, in a couple of months, you can move it a couple hundred points. I mean, and this is assuming you're a non-smoker, generally healthy, no, systemic disease like diabetes. Inflammation can use these nutrients up too. And so, and I think, going back slightly to your previous question, the topic, this idea of a good diet is an interesting one. And, when we talk nutrition, for over 100 years now, doctors are like, diet and exercise, right? Do it. So people say, oh, I've got a good diet.
Yeah.
And I'm sure you've heard this as clinicians,
course.
my diet's fine, And so that definition is not standardized at all. And it can be really wildly variable,
I only eat McDonald's once a week.
Yeah, right, exactly. Or they say, well, I eat, a couple salads a month and I have a piece of fish on, the last day of the month, whatever it is. And it's like, well, you got to do it consistently. And this is where, you get those benefits. And so it's been frustrating. I know for John and I, we see these things in the lab measuring very carefully, and we see these really strong effects, visual performance effects, holding off disease progression. These things are very real, but you've got to be consistent with, and compliance is huge. This is a truth teller. It will tell you, the clinician, if your patients are compliant. It'll tell you if they are compliant and it's not moving, something else is going on. I mean, there's something happening. For the patient, it's very reinforcing. You see the number, like you mentioned, patients go for, all the numbers they want to, and I measure athletes and they're very competitive. They want to go up too, know? And so like with your dad, there are things he mentioned to me, he struggles a little bit with glare at night, oncoming headlights, that kind of stuff, vision in low light. And so those things start to turn the corner after a few months, consistent, adherence to either a supplement or a very good diet. But yeah, in this case, I'm very excited to see where he's at.
What I think about some of those symptoms, and Harvey, you and I have talked about this before as well, is just that, the glare, when I think, I don't know if it's just bias, but I always think, glare at night, 65 years old, you got cataracts, you know what I mean? Mm-hmm, mm-hmm. And so these kinds of ideas where we know we can start to improve some of the contrast sensitivity and even improve some of our nighttime vision symptoms, and glare may be one of them, sure. By having better carotenoids, just sort of is mind-blowing and almost game-changing, where you are now considering macular function in conditions that are historically thought about as lenticular.
Yeah.
Well, I'll make a comment to you, Chris. So my night vision has gotten significantly better. I'm 74 years old, have had bilateral cataract surgery, so there are no cataracts. I've had the capsules opened, so that's done. Had the capsulotomies, as happens a lot of times. The quality of my vision at night is far better. I never wanted to drive at night. It doesn't bother me anymore. And it's really amazing for me to see that. For so many years, I was a high myope, and so we tend not to like nighttime vision better. So it's been real. It's very real.
Yeah. Well, and so the if we're going to kind of bridge the gap of kind of how do I know that the LifeMeter, which measures pigment optical density in my fingers, how do I know that that's going to correlate to my macula? So we've got to get it by, obviously, if we can increase the numbers, and I'm sure that we've got some studies that you can talk about related to consuming carotenoids, leading to an increase in serum levels of carotenoids. That's what we're measuring through the LifeMeter, and knowing that if that level is higher, then the macular pigment is going to be more dense as well. How do we get to that point? Because that's kind of sort of the only case that could be made from using a macular optical pigment density measure, that we could say, well, this is in your blood, but it's not in your macula. So tell me, how do we get there?
A couple of points, and a couple of ways to answer that question. In the first instance, let's be very clear. I agree with Jim that you'll see the changes in the skin maybe 3-4 weeks into consistent supplementation. That doesn't mean that the macular carotenoids in the eye have changed at that point in time. We know from our studies that in a valid measure, when we use like proper objective assessment of macular pigment, you're looking at really 6 months to turn the needle in the eye. But how do we know that there's a correlation? And there's different ways to look at it. Before any interventions, let's talk about what our data shows us. Number one, HPLC of blood or skin, but we're not gonna excise skin from living people to do that analysis. But we can take blood, draw blood. That's very specific, very exact, very time consuming, very expensive. Again, not clinic friendly. So this is one way we know to measure with exactness the carotenoids that we're interested in. We know from all my studies, all Jim's studies, and from many other people across the world, that blood carotenoid concentrations are a really good correlate of retinal carotenoid macular pigments. So that that stands up cross-sectionally. The good news is I have been using skin carotenoid measurement as part of my experiments, interventional experiments, now for many years. And I can confirm, and we have studies, that when you supplement with Macuol specifically, you will change the blood levels and you will change the skin carotenoid levels, and they correlate highly well together. So the change that we see does really good together, and that also correlates with the macular pigment levels. So the value of this is not just that we've been able to correlate this new technology with blood levels. We have absolutely been able to demonstrate that supplementation will change macular pigment level, and that correlates with the functions that we've been talking about. So we've done the work.
Yeah. Well, I think the only other question I would have would be, from a clinical standpoint, or even just a scientific standpoint, is when they don't correlate, how often does that occur, and what are your thoughts on, well, if they don't correlate, how often does that occur, and if it occurs, why, like, what's the mechanism underlying? So is there a 1 in 100 chance that you're not going to elevate it if you're...
Well, if we don't elevate the blood,
right,
we have a non-responder. You're not going to elevate the skin. You're not going to elevate the... I've never seen a situation that we've had a responder in blood and not in skin.
So so then that's interesting. Then we could, have the conversation of, well, Steve, my dad, you've been taking your supplement once a day, just like we've discussed, and your levels are 250, and he's adamant that he doesn't. So what's the next step? How do you know he's a non-responder? Does he have other enzymes that are not that are not absorbing this the right way? Do we increase his dose? What do you know? Like, what can we gain from
There'd
that?
be a couple of factors to look at. Maybe Jim would like to add to it, but one would be we always have to be cognizant of lipoprotein profiles, the role they play. The journey of the carotenoid to be absorbed is quite complicated. We're talking about fat-soluble nutrients that go into a water-based system that have to be encapsulated into a micromicelle that have to be transferred through the intestinal wall, lymph system, and then into the blood system. So there's a bit of work to do, and that's why we celebrate the new technologies of micromicelle, because it has allowed us in a research world inform the clinic world on how to get a better result for all of your patients. So that's important. I'm not sure if you want to add to that.
Yeah, that's right. Well, I think primarily it's an absorption thing, I would guess. That would be my first guess. The second is that, I think that we tend to look at carotenoids and the end organs where they get deposited, the retina, the skin, lycopene gets deposited in the prostate if you're a male, those kinds of things. But these nutrients, the body is super efficient, and it's identified these nutrients that it's expecting to get in a lot. Now, granted, a lot of people don't eat them, but they're used systemically as well. And so it turns the blood into this antioxidant machine, and it breaks the chain of inflammation. And so my next guess, outside of absorption issues, would be systemic inflammation. And if there's something going on. I mean, diabetes is a great example. It's a systemic inflammatory disease, and so you've got adipocytes, the fatty, that release inflammation into the blood. I mean, and that can reduce these carotenoids, so the body's getting used up before they.
One other really important point, Chris, that you've alerted my brain to, and that is, and it's back to absorption. That's competition. So and that's why I get sometimes, like, we can be casual about, okay, if lutein's working, it's working, but back to the whole understanding of what's actually in the supplement piece. So, for example, if you had beta carotene in a supplement that you knew you were taking, or that you didn't, even worse, you didn't know you were taking, that will have an effect on your dad's ability to absorb the lutein. So he's taking a supplement to get the benefit of the lutein, because these are the specific carotenoids, lutein, zeaxanthin, and meso, as we know. So that's what you need. You can have competition between these carotenoids. Well, that's important.
That brings up an interesting point then, because the other side of the coin that you would hear often is why we don't need to have mesozeaxanthin supplemented, because it's going to compete with, and we can convert lutein into mesozeaxanthin. So why is that not part of the competition?
Have you another hour for this chat?
Well,
I'm joking.
We got a little time.
I'm willing to give you some time for it.
Yeah. Okay. Do you want to go?
So you go ahead.
You brought up the interesting part about competition, and I know I've looked at the literature in depth of that competition. So I think let's explore that a little bit, because it is interesting.
Well, ARET showed us very clearly that high beta carotene consumption suppresses lutein. So I always explain that the blood system is like a taxi system, and if we over supplement with any one carotenoid, you will suppress another carotenoid, and that's why getting the balance right in the formulation. You know, with our interventions in Waterford, we didn't just pick MacuHealth Health. We looked at all different variations of the carotenoids that we could work with. It happened to be that the MacuHealth Health 10-10-2 was the one gave us the best results, so I chose that for the experiments. So that's important. To the meso point, okay, so what we know is that we have about 15% of the population that have what we've coined, and it's been validated by my centre, but other centres now from across the world. Instead of having your mountain profile, you have this kind of volcano, this dip centrally. And we know from the anatomy studies that when you analyse a retina macula, you'll see that the zeaxanthins, Paul Bernstein has recently done beautiful work on this, even imaging showing zeaxanthin and mesozeaxanthin being the very central carotenoids. So many years ago, I hypothesized that the dips that we were seeing, which I confirmed were real, which we knew were highly prevalent in those at high risk of macular degeneration, were because of a deficiency of mesozeaxanthin and an inability of that patient, maybe enzymatic, to do that lutein conversion. So that's why, lutein on its own is not enough,
So you basically, so MacuHealth, the 10-10-2 formulation is basically solved for that 15% of patients who are going to have dips because they can't convert lutein into mesozeaxanthin.
Well, we came from a world where in my interventional studies, we had about 15-20% non-responders to a world where we have 100% response.
Yeah, it was frustrating because we do supplements back in the late 90s and early 2000s. The only available supplements were just lutein alone or lutein and zeaxanthin, and you'd get and these are in normal individuals. These aren't folks at risk necessarily. They're college-age students, 15 to 20% non-responders in the center. And they're like, what is going on? They're going up in the blood, not in the eye. So it wasn't an absorption issue. And then there are recent reports that indicate that around 40 to 50% of those with AMD have this deficient conversion enzyme. It's a continuum. Sometimes the enzyme doesn't necessarily work at all. Sometimes it's slightly deficient, and so it's interesting that the genetics for all of this seem to fit, and so of course that's right where you need the densest pigment is right in the center, over that foveola, and where the highest cone photoreceptor density is, and potential for oxidative stress, etc. Light focus.
I think we need to be clear as well with the skin measurement. We're measuring a composite of carotenoids. We're not measuring any particular carotenoid. So there's other carotenoids in the skin that are not found in the macula. So lycopene.
And that doesn't confound the because
the surprise to me. The surprise to me was I wondered, and I actually didn't believe that taking lutein, zeaxanthin, and meso would change the needle in skin the way we've seen it, because I thought you'd be looking at more of a lycopene or a beta carotene supplement to do that. But actually, now looking at the HPLC data on skin carotenoids, and it matches perfect that of blood. So lutein is a very big, zeaxanthin very big present in skin, and I know from our animal works as well, when we do this, we were able to look at all parts of when we worked with the hen model and we did interventions. That was where we actually started our work in terms of bioavailability and the micromycel diacetate. You can see that these carotenoids have to kind of fill up the reservoirs within ourselves. They're fat soluble, right? So some of us have nearly 50% fat in our bodies. We don't want it to be in that place, but maybe 25% anyway. So there's a lot to kind of satisfy before we can target it to the tissues, the retina and the brain. So
I like the idea of the 6 month, and so I think that kind of will allow us to wrap up the conversation maybe with a clinical discussion, Harvey, of if we're going to integrate this into a practice like mine, which I don't have this yet, would be okay. Well, Harvey, you're saying, look, we're thinking about visual function beyond macular degeneration now. So if I'm convinced that that's what I want to do, then how do I set this up in my practice so that it's minimally impactful on the patient flow and maximally impactful in the conversations I get to have with patients?
So I think there's a couple of ways you can do that, Chris. Some practices when I've talked to doctors, actually want to have it done at the front desk. And we have offices doing that on every patient. There are some practices that want to have it done by their technician as part of their pretest. It's a very quick test. Jim, what's it take? 3 minutes?
Yeah, under 3 minutes, probably
Okay.
2.
So, and some doctors say 3 minutes. I got to save 3 minutes. Well, you know my philosophy about how long we spend with patients.
Yeah.
It's a lot longer than that. So, I personally believe that when you're doing a medical test, you want to show value, and you do it as part of the medical testing. I think I'm not the one that loves the idea of the front desk, but it seems to be an idea that doctors believe will work well for them. So I think there's different ways to incorporate it. I think what has to happen is that number needs to follow the patient. So either the technician or the doctor, or perhaps if you have a trained person at the front that understands it on the patient's way out, that they can be going through that with the patient about their number. So I think that's how you do that. I want to make one observation to you, Chris, because I was listening to the conversation about what happens if that number doesn't go up.
Yeah.
And what enters my mind if I'm the practitioner and I have a younger person in the 20s or 30s where their number doesn't increase, the first question I guess I would ask at that point is, when's the last time you had a physical exam? Is there something systemically going on in an inflammatory way that may be taking these carotenoids and using them? Because we know that the average younger person doesn't have regular physical examinations. And there may be things going on now that are going to rear their ugly head coming in the future. So I look at this in a couple of different ways of how we as a clinician can look at not only a number for the patient, whether it's done at the front desk or whether it's done in a tech setting, but what do we see when the follow-up number occurs?
Yeah,
and
that's the challenge.
And it's not what we think it should be.
Yeah.
Are we going to be the full scope practitioner and discuss that with them, or are we just going to focus on those two eyes 6 inches apart and that's it?
Yeah.
I think we need to be the full scope practitioner.
Yeah, I would agree. I think that's the challenge from a lot of people that would be that. Okay, well, what happens? It's the same thing when we think about dry eye. I prescribe this treatment and the patient doesn't feel better. Or even if I'm measuring all the numbers, well, what's next? Well, if you've got, then it's like, well, now we got to figure out what's next. And if you're willing to figure out what's next and have the conversation with, well, let's see if there's something else systemically going on, or, maybe we are absorbing too much in our adipose tissue, then you have to be willing to have the conversation, but also not letting the small potential for having to have that conversation break down the good that you could do. Last question. How many patients do I need to treat with this in order to harm somebody? What's the harm that's going to come from, patients asymptomatic, young, we measure them and their numbers are low. And so we talk to them, they understand the importance, they do it. How am I going to harm that patient? Is there any downside? I think a lot of times we wonder about the downside, or we don't wonder about the downside effects of a nutraceutical. But are there any? For that long duration 30-year-old patient, we think of only benefit, only visual benefit. But are they going to, is there a potential, obviously the cost, they have, there's a cost involved, but is there an anxiety now that all of a sudden they're worried about other things? Is there, and I haven't seen it. I'm just trying to think, well, what's the downside of treating somebody for years and years and years in supplementation? You might know this better.
Yeah, I was going to go cost.
Yeah.
That's the primary one, I would think, because, medically, there have been so many toxicity, mutagenicity studies that have shown, that you can throw 3,000 milligrams a day at the human body. And you worry about lipid-soluble nutrients with the liver. The liver enzymes don't change. The saturation, if the body is saturated, it gets rid of the nutrients. There's really cool transport systems that help with that. So medically, virtually no risk. And that's, I've dug deep into this. I know Professor Nolan has as well. There's just adverse events. I've measured thousands of individuals. I know John has as well in his studies. I've never reported an adverse event in a study.
No, I mean, I've done a scan of the literature as well. And one of the things I wonder, again, not knowing all of the excretionary or excretory mechanisms, but one of the things I thought about is, well, are there oxalates? Would we worry about like patients that would have kidney stones or any of those sorts of things? But that's not even the same pathway as...
No, it's not. And you would get that from leafy greens if you were to eat the actual greens.
That's right. Not in the carotenoid itself.
Not in the purified carotenoids,
so that was the one thing I was thinking about too, is like, okay, well, maybe we already are high and we're trying to excrete these and then they get bogged down in the plumbing.
Yeah, it's a good thought, but no, that's not the case.
The only other... if we look at ARIDS again, to go back to the ARIDS, they made a very careful decision to remove beta-carotene once again because of the significantly high risk of lung cancer in cigarette smokers.
Right.
So that's the beta-carotene is important. In some instances, we need to obtain it from our diet and so on. But in terms of targeting the macula to deal with this specific condition, we know how to do it.
Yeah.
And most nutrients we need, enough, but not too much. You talk about like zinc, for instance.
Right.
I mean, it's a little bit horrifying how much is in the ARIDS 2 formulations, 80 milligrams. But that's a topic for another day. But we need about 10 or 11 milligrams a day, and then really not much more. And we don't, the FDA set the upper tolerable limit at 40 milligrams a day, and yet we've got 80. And that's
and the most widely used.
Yes.
Oh, it scares me.
So,
it really scares. I mean, it can be neurotoxic, right? So anyway.
When I won the CREST program in 2011, one of the big claims I had in the grant was that we had identified a deficiency in specific nutrients that needed to be addressed because of nutrition and evolution, because of the basic fact that our kids are not consuming enough during their life, even homes that are fortunate and have access to good foods, we're 20 times away from where we need to be.
Yeah.
And that's why I'm asking, John, are you saying that you think everyone should be on this supplement? Yes, I am.
Yeah.
100%.
Yeah. All right. So I'm going to be respectful of your time. Tell me, how do I get a hold of this LifeMeter and any other parting thoughts? Nobody here knows how to get
I think
we're the scientists.
MacuHealth is selling the LifeMeter. MacuHealth is a supplement company. Okay, they are not an equipment company. This is not their science. This is a science that's been developed by a very, very smart scientist. And there are many studies about this technology that proves it. So the sales team for MacuHealth will have the LifeMeter. They're going to be able to demonstrate it. They're going to be able to give you the information about it as a practitioner. And I think the key is to actually try to see it and to test yourself, test your staff. That's been the real interesting thing. Doctors sometimes supplement themselves and they find they're doing pretty well, and then they test their staff and their staff's at 200, 210. But you can get this through MacuHealth and their sales reps.
It's a very sophisticated kit. It's a spectrophotometer essentially. It's equivalent to what we have in the best lab in the world. But the magic here is it's been able to be made into a size and available to what will work in the clinic, and that's what's unique about this.
Yeah.
That's right. And it's not tied to any supplement.
Yeah.
You use it how you want to use it if you buy it.
Yeah, I think that's great. So, John, Harvey, Jim, thanks again so much for being on the podcast. I really appreciate it. It's been a lot of fun.
Thank you, Chris.
Thanks for having us.
Thanks for having us.
Appreciate it.
You're welcome. Thanks, guys.